So I'm going to talk about procalcitonin in relation with COVID-19. And so procalcitonin is the precursor for calcitonin, and it's synthesized by the calca gene that is expressed in different tissues. And it will lead to a precursor called pro-calcitonin that will be processed into calcitonin later. But in different tissues, there are alternative splicing, leading rise to another peptide, especially in neuronal cells. So procalcitonin is a single polypeptide of 116 amino acids. It's quite a small protein. And although it's the precursor for calcitonin, it doesn't exert any effect on the calcium metabolism. So different tissues may produce the peptide, but it's mainly in the thyroid C cells that significant synthesis is observed, and to the second point in lung K cells too. So on the picture here, you can see a procalcitonin, and in red, the resulting calcitonin that displays only 32 amino acids. And so, as you can see here, the expression of the gene has been studied in different tissues, and it's mainly, as I said, thyroid that produces the peptide, and in thyroid cells, procalcitonin is processed by pro-hormone convertase to give rise to the calcitonin that is secreted in the blood circulation. In normal people without infection or inflammation, blood levels of procalcitonin are very, very low or not detectable. And in 1993, a French team described high levels of this peptide in different type of patients, but mainly patients suffering from bacterial infection. On the left, you can see different types of patients, mainly suffering from burns with secondary bacterial infections, showing high levels with different kinetics. And maybe more interesting to the right, the same team in the same article described PCT levels in neonates and infants suffering from bacterial infection, and the evolution of these concentrations after treatment by antimicrobial agents. You can see too that in case of localized infection, the levels are increased upper limit, but to a lesser extent. And same picture can be observed in viral infection in most of the cases, but as you can see, and it's quite important, high levels may be observed in some cases of viral infection. So in these conditions, in sepsis, but also in other types of inflammation, actually, pro-inflammatory cytokines like interleukin 1 beta, TNF alpha, but also IL-6 will stimulate the synthesis and the expression of the gene and the synthesis of procalcitonin. And that can be seen, for example, in experiments with the injection to volunteers of endotoxin. And in viral infection, the high levels of interferon gamma will partly repress the secretion of PCT. That's why lower levels are seen actually in viral infection as compared to bacterial infection. And in these conditions, the expression is not limited to thyroid, but most tissues will secrete PCT, and probably the main source is the liver. And in these tissues, the pro-hormone convertase are not expressed, and then that's why PCT is secreted and not calcitonin. So many studies have been published over the last 10, 20 or 25 years and about the kinetics of PCT and other things, of course, but the PCT is quite interesting, as you can see, as compared to CRP. PCT starts earlier within 2 to 4 hours, with a shorter half-life of 24 hours. Of course, it will be later than pro-inflammatory cytokines, but quicker than CRP. That's maybe one advantage among others. Also, from the diagnosis performances are better for PCT. For example, for the diagnosis of sepsis, as you can see on the right, the sensitivity and the specificity of PCT is slightly higher than CRP. So what are the main interests of PCT measurements in general? Well, it's firstly mainly to discriminate between bacterial and viral disease, mainly in lower respiratory tract infections and other infections, and also for sepsis, with a correlation between levels and the severity. Of course, that can be discussed because in some cases, as you will see, when inflammation is too high, in severe sepsis, for example, non-specificity may appear. And the second main interest is antibiotic stewardships. Different studies have been performed over the last years showing the interest and the economic interest of a reduced antibiotic exposure, because as displayed on this picture, the efficacy of the antibiotic will be reflected by a decrease in PCT levels, as can be seen with CRP in some cases. And so some studies demonstrate a reduced ICU stay for patients in sepsis, but fail to demonstrate a real significant decrease in mortality. So this is an example of a recent study comparing infections of viral origins and bacterial origins. This was performed on a high number of patients, and indeed there is a statistical difference, a significant difference between viral and bacterial infection, but there is no clear threshold to make the difference between both conditions. So indeed, values are different, but the diagnosis won't be that clear. This is an example of the economic study of the interest in the antimicrobial therapy use, showing indeed that the length of stay will be decreased and the exposure to antibiotics will be decreased, with, of course, a good interest for the patients in the institution. But more recent reviews, like this meta-analysis, demonstrate that there is a low certainty evidence, and that especially on the basis of mortality, more studies and well-performed protocols should be made. Anyway, there are some guidelines, and these kind of guidelines are applied in some of our hospitals to guide the use of antimicrobial drugs in different conditions outside the ICU or within the ICU. There are some limitations for the use of PCT, for example, in neonates during the first days, and that's important in patients with major stress, like severe trauma, surgery, cardiogenic shock. Other causes of non-specific increased are kidney insufficiency, kidney failure, for example, and so on. Now, what about the interest of PCT in COVID-19? First of all, I would like to show you an interesting picture, and this is the evolution of the number of tests, of PC tests performed in our lab. So we started with PCT last year, and we had only 10 to 20 tests a week until March, where we saw a big increase, something that we could call the first wave of PCT. And then in July, we had a mini wave, and maybe now we have something that could be called a second wave. I should ask Ivan Latam if we can call it a second wave. But indeed, the picture is quite close to the evolution of positive PCR tests for SARS-CoV-2, of course. So it looked like PCT is interesting for our clinicians following the patients with COVID-19. And what can be found in the literature about that? Actually, not that much. First of all, the PCT is a marker for COVID-19 severity, and secondly, that it might be interesting to make the differential diagnosis with bacterial infection or to detect maybe secondary bacterial infections. And so there are mainly dozens of articles studying the different inflammatory markers, not especially PCTs. A few studies focused on PCT, but most are studying different. And of course, the evolution of different interleukins and acute phase reactants is parallel to PCT in several cases. And indeed, in critical patients, higher PCT values are clearly detected than in patients with mild forms, and also in patients that will die or that died later, higher levels of PCT have been observed. Maybe this study is quite interesting because it showed also that high PCT values, initial high PCT values were associated with a longer use of ventilation. And so, but it's also a reflection of severity, of course. And finally, this meta-analysis is found in different other papers. It was performed by an Italian team, the team of Plebani, showing that indeed there is an odd ratio of about 5 of severe forms of COVID-19 in patients with high levels of PCT. Regarding bacterial infection, actually, this hypothesis is detailed in many articles, and severity is linked to potential bacterial infection, but there is actually no clear demonstration of that. I only found one article talking about the subject, but actually it's still a preprint article since July, so I'm afraid it won't be published ever. But so in this study, including several hundreds of patients, the authors said that indeed a high PCT value decreased the probability of having a positive COVID PCR test. So probably we can imagine that these patients have a mild or a moderate form of COVID-19. There is also another study that, oh, sorry, I forgot this. This is a recent meta-analysis published in a Belgian journal by an Italian team, and they say exactly the same. So they studied, they made a comparative study of the role of PCT for severity, and they found, of course, what I presented just before, but regarding bacterial infections, they could not find anything interesting. So we performed at CHU Saint-Pierre a study, actually my colleague from the emergency department performed that study, and we did cooperate with the clinical chemistry lab and the microbiology lab. And so all patients consulting the department during March and April were included. Finally, only the patients who had the PCT test were included, and among them, most had a viral community acquired pneumopathy, of course, so it was the focus of the study. And we did finally compare the PCT values in these two groups. And as you can see, actually, we did not see any difference in PCT values in viral-proven pneumonia as compared to bacterial-proven pneumonia. What we should say is that indeed we had high PCT values in the viral leg and in the viral arm, sorry. And so probably these patients had already quite severe forms, and of course that was during the first wave. So in conclusion, I would say that PCT is macroinflammation, indeed, and partly specific for bacterial infection, but only partly. And it's not surprising that this test is still controversial and not reimbursed in Belgium. In the case of COVID-19, indeed, several forms are associated with high PCT, but also other markers. PCT values are, however, similar in bacterial and SARS-CoV-2 pneumonia, and it doesn't look to be helpful to distinguish between the inflammatory phase or a secondary bacterial infection. So I would like to finish with some thanks to my colleague, Cécile Azoulay-Rupierus, a trainee who did the validation of the test, my colleagues of the core lab and of the emergency department. And I'm not sure I would like to thank the other two people, but it's only because this picture was quite funny. Thank you for listening. Questions?
Yes. Have you heard about a movement?
So the question about the reimbursement, I don't think it's no, I don't think it's a pipeline for the moment. Personally, I would not support it. I think so. We performed the test because it was required by clinicians, but yeah, in the literature, if you read all the articles, it's not that clear if the marker is really helpful. And as you can see in our study. Actually, 30% of bacterial-proven pneumonia had normal PCT test. That means that they would, if we had followed PCT, we would not have given them the right treatment. So I think it's maybe can be dangerous in some cases. So is there a point of care test? So a POCT for PCT? Yes, of course, there are different instruments, including some gasometry instruments that provide the test. So yeah, it might be helpful. I prefer not to tell that to the clinicians because I'm sure they would like to get it, but I'm not sure it will be very costly. I'm not sure it will be very helpful. So thank you very much for